how partnerships between the state, managed care organizations, and providers can be leveraged to implement the model, and the benefits that Washington has observed to carving in behavioral health services. The webinar will also provide an overview of programs and services launched as a result of the behavioral health integration efforts and lessons learned. This topic is near and dear to my heart. Arizona spent the last decade better integrating services between behavioral health and physical health services. We started our journey in Arizona over a decade ago by focusing on individuals with serious mental illness. In Arizona, that population died on average 30 years younger than peers, and oftentimes it was because of untreated chronic conditions. Arizona spent considerable efforts focused on looking at ways to drive policy in terms of what the state was doing, focused on things like how can we better support providers in integration efforts by removing burdensome regulations. We focused on payer strategies and how payers could better integrate the delivery of behavioral health and physical health services in terms of thinking about care coordination expectations and provider services. And then we thought about and developed programs to support providers on their integration services, coming up with $300 million in infrastructure investments for providers in terms of looking at ways to better serve individuals holistically. All of this resulted in a third-party analysis that found in Arizona, when CAP survey data was reviewed, all measures improved, and 5 of the 8 measures improved by double digit. And so we see the proof in terms of some of the hopes of integration to better serve complex individuals and better meet the needs of the Medicaid population. And we're excited to hear today from the Washington example. Before we get to the agenda, I wanted to note that all attendees will remain on listen-only mode, and that we certainly want to hear from you in terms of questions you may have, so drop them in the Q&A box, and we'll have time at the end of the webinar today to answer those questions. During the webinar today, we'll hear short presentations from Jason McGill. Jason is the Assistant Director of the Medicaid Program Operations and Integrity at Washington State Healthcare Authority. From Drew Hill, Chief Executive Officer of Excelsior Wellness, and Dr. Sasha Waring, Behavioral Health Medical Director, Molina Healthcare. The presentations will be followed by a panel discussion with all the speakers. And as I mentioned earlier, we'll use the last 10 minutes or so to address question and answers raised by those of you attending today's webinar. Our first speaker today is Jason McGill. Jason is the Assistant Director of Medicaid Program Operations and Integrity at the Washington State Healthcare Authority. He previously served 2 governors for Washington as Senior Health Policy Advisor. He led the governor's health and related strategic vision, goals, and policy initiatives. His services spanned critical times from the deep recession to implementing the ACA, and now through the COVID-19 pandemic. Then we'll hear from Drew Hill. Drew is the Chief Executive Officer at Excelsior Wellness, a nonprofit continuum of healthcare, education, social, and human services organizations in the Inland Northwest. Drew also currently serves as a governor-appointed partnership council on juvenile justice member, committed to reforming juvenile justice system. Before becoming CEO of Excelsior Wellness, Drew served as an American Red Cross authorized provider, military and family life consultant, and a director for several youth character development organizations. Finally, we'll hear from Dr. Sasha Waring. Dr. Waring is the Senior Medical Director for Behavioral Health at Molina Healthcare of Washington, a company that is focused exclusively on government-sponsored healthcare programs for families and individuals who qualify for government-sponsored healthcare. He has 5 years of experience in managed care in Washington. Prior to these roles, Sasha served as a consulting psychiatrist in integrated primary care behavioral health programs in California and Washington. He's a child, adolescent, and adult psychiatrist. So with those introductions out of the way, Jason, let me turn it over to you to kick off our conversation around behavioral health integration in the state of Washington.
Great, thank you, Tom. Welcome, everybody. I'm glad to be with you, and especially glad we have Drew and Sasha today, who will bring real life examples to this work. I'll talk a little bit about the structure and some of the policy and development, system development wise, we've worked here in Washington. Next. This slide really is a landscape slide. We're at the end of the beginning, folks, with regard to integration here in Washington. We have a long way to go. As you can see, we have a long road behind us as well. And this doesn't even include the pandemic, which of course we cannot ignore the massive changes with regard to our behavioral health system, the capacity and workforce challenges that have occurred as a result there as well. But integration is, I would say, on the financial side of the equation, going well. We've got lots of challenges. We have lots of opportunities ahead. But on the clinical side, I think is our major opportunity, really to find ways to engage primary care, to find ways to engage our behavioral health community system, building out our community health, behavioral health system, and then working together and finding that sort of bi-directional care, whether it's primary care or behavioral health care. We have behavioral health transformation underway from a perspective of working towards becoming the certified community behavioral health clinic model and a state demonstration. We also have our primary care transformation underway. So a lot of different dynamics impacting the system. Right now and over pandemic, workforce has been critical. Paying rates that are necessary to support a workforce. We are still far behind where we probably should be to ensure we've got good retention and recruitment for behavioral health specialists across the state. Not to mention the demands for additional services. We must do a better job to prevent suicide. We must improve our systems. So 988 and that work has been so critical. And as I said, we're still building out a community behavioral health system and finding good, creative, and innovative ways to do so. We must continue with state policy, not only legislation, but budget, and look to ways. In Washington, we have our new 1115 Medicaid transformation waiver renewal in for CMS consideration, of which integration and particularly SUD and opioid treatment, now with fentanyl increasing across the nation and in our state, overdose related to fentanyl is a incredible challenge. Post-acute transitions and really preventative work is key. So a lot of hospital and system capacity challenges right now, and we must keep attention on these issues. Managed care brings some great virtue and value, and not only in terms of financing the system, working through actuarially sound rates gives us some really important foundation to ensuring we've got network and capacity. But really we need metrics, and we need to understand network, and we need to work with our providers and our system to continuously improve and innovate. And you'll hear from Andrew more about that and Dr. Waring about what our managed care plans are doing. Next slide, please. And I'll just move through these very quickly to make the point that we have to, as a state, measure. We've got to include a good host of metrics. And here is a snapshot of what we include in Washington. Next. Homelessness, employment. With regard to what we call our SUD penetration rates, these are really follow up. You've got a diagnosis now. We need to make sure you get follow-up treatment. And our managed care plans are held to accountability for these metrics. Next. Here's just a graphic view of how we do this, a bit of a report card and benchmarking against our 5 managed care plans in Washington. And it is a good way to not only compete a little bit and to make one plan perhaps want to do a little bit more best practices and to share those best practices amongst different managed care plans. Next. And I think these slides, again, just show a little bit more detail. And I think just making the general point that it is critical that we're measuring this work. Next. And next. There is a savings that is promising. This is not why we're doing this, folks. But we do have some good indication that there is cost savings in the system, but it is the right thing to do. And we'd really. Next, please. And the final point I wanted to make was really just network adequacy. There's a lot of innovation here that needs to happen. We have a system of sort of formulaic time and distance standards today, not really capacity and access standards. So we need to not only ensure we've got behavioral health providers and understand those critical providers as part of our network adequacy review, but we also need to look for better ways to assess capacity and access. And just a couple of slides here to show what we're looking at today. Next. This is our network file. So we're tracking all of this data. Next. Here it gives you sort of a bubble slide of what we're looking at in terms of state access. So obviously we've got some issues in SUD, youth, outpatient. And so we're working with our managed care plans today on corrective action and really a performance improvement planning on that. Next. And just information for you for follow-up. But really, I think you will love to hear Drew, who is a provider that we're working with trying to find ways to do new and innovative things, such as peer services in K-12 and really fostering that work. Improving our behavioral health care, not only as an important regional provider writ large, but really some very innovative things, particularly children and youth related. Drew, please.
Thank you, Jason. And thank you to everyone here for sharing this space with me today. Hello and good afternoon. My name is Andrew Hill, CEO for Excelsior Wellness here in Washington State. And I'm going to start today talking about how integration provided opportunities for participant convenience and efficiency in the delivery system. Integration has always made sense to Excelsior. We served populations with complex needs, under-resourced, and experienced significant barriers when helping people navigate the healthcare system. To help solve this challenge in the 80s, we began co-locating providers, developed relationships with specialists, and built in-house expertise in care coordination across our system. We took the commitment of our team, about 100 years of institutional knowledge and emerging methods for working with youth in foster care, and started applying that to the community. About 2 decades ago, the recommendations to completely transform the US healthcare system pointed to a model of integrated care. At that time, Excelsior had around 20 years experience providing holistic care for some of the most underserved young people in our state. The importance of an integrated model became clearer to us when the Institute of Healthcare Improvement launched the Triple Aim. That was about 2007, focusing on improving both population health and the participants' experience of care and lowering healthcare costs. In 2014, the Triple Aim expanded to become the Quadruple Aim, adding in the improvement of provider satisfaction, which today is paramount in trying to recruit and retain a workforce. Our experience is one that integrated and aligned systems reduce costs and barriers associated with care coordination and allows for improved referral systems that lead to more timely access to needed care. It reduces system complexities that are costly and create barriers to care. Next slide, please. Here we'll talk about the structural care delivery, operational components, the ones that make it work, which aren't easy. Excelsior Wellness currently has a high level of integration between health and human service providers that includes co-location, braided and blended funding, shared records and registries, and cross-system peers to help people navigate the system of care, whether within or outside of our delivery system, and at any level of care. Integrated services are provided in a mix of co-located and separate care settings, depending on the needs of the participant. This includes various shared physical settings for medical and behavioral health, and various levels of integration between medical and behavioral health system partners. The behavioral health continuum of care includes social and human services, hosted by several entities, including Excelsior Wellness Center. And that's where our community behavioral health and CCBHC is delivered. Excelsior Family Medicine delivers primary care and family medicine, foster care specialty services, and a collaborative care model that integrates behavioral health services into primary care for mild and moderate care. Medical and behavioral health providers are also co-located to promote school-based healthcare at area school districts and within our own Excelsior holistic schools. More acute behavioral health needs are delivered through our hospital healthcare entity, the Integrated Care Center. This is where individuals and families are offered higher skilled care and expedited access to our continuum of services through Meet Excelsior, which promotes engagement, respite, stabilization services at any level. Finally, our system includes Excelsior Solutions, which hosts the system's business-to-business functions, cross-organization infrastructure to lower costs, and hosts technology for our Community Wellness Alliance. Next slide, please. Next, I'll discuss collaboration. Early on, Excelsior developed the ability to speak fluently within each siloed system, and our focus became the development and facilitation of cross-system care coordination hubs. It was not just essential to understand each system's effort, we also had to eliminate duplicative effort, and we had to braid funding into one lower cost effort. More importantly, cross-system language translation and better understanding each unique system barriers helped care coordinators establish one plan for people. That's what it's all about. Another important collaboration in 2018, Excelsior created the Integrated Managed Care Collaborative, known today as the Community Wellness Alliance. The Alliance allows for providers to practice varying levels of integration, shared electronic records, and seeks to supplement the ongoing health information exchange technology development in our state. Finally, some of the most innovative came from long-term collaborations. Innovations came from long-term collaborations with partners represented here, such as the System of Care Partnership Jason mentioned with the Healthcare Authority, and our targeted population, transition age youth, and rural access programs with Molina. Next slide, please. Lastly, today, I want to highlight the impact on the beneficiary. Beneficiaries have experienced improved engagement and better access to the appropriate services when and where they need them. Through structured shared decision-making, participants are more directly engaged in their healthcare. Beneficiaries receive assistance navigating complex systems through effective and efficient care coordination and peer support advocacy, thereby reducing many of the systemic and structural barriers to care, improving equity and access to resources. Our participants justly demand increased access to holistic, person-centered care, focused on redefining what wellness is. We understand the disease model of care, and we promote opportunities through a wellness and recovery model of care. We see more awareness in our participants that mental health care is healthcare. We still have a long way to go, but we're starting to see the changes and the benefits. And with that, let me pass it on to Dr. Waring.
Thanks so much, Drew. And thank you for the introduction, Tom. It's an honor to join you all today alongside Jason and Drew. In the 5 years since I took my first role in Medicaid managed care in Washington, I have learned repeatedly that effective collaboration between state agencies, direct service providers, and health plans is necessary for our system of care to meet its goals. Today's webinar, therefore, is a great opportunity for Jason, Drew, and I to speak in greater detail about our respective organizations' individual and collective efforts to care for Washington residents from a whole person perspective. Molina Healthcare is a national health plan offering government-funded insurance in now more than 20 states. In Washington, Molina is the largest of the Medicaid plans with approximately 1 million members. Our size in the Washington market provides both specific opportunities as well as specific challenges in all aspects of delivering high-quality managed care to our members. When Washington State transitioned to integrated managed care, Molina and the 4 other managed care plans had a great deal of work to do to make a successful transition in each region of the state. I will use the next 5 or so minutes to talk a bit about what we have done, what we are doing now, and what we plan to do in the near future to make integrated managed care serve the millions of Washington residents who rely on this system for their healthcare. Next slide, please. Adapting to thrive. So some of the ways, the most critical ways that Molina needed to change in order to implement integrated managed care. As I already mentioned, partnerships have been critical at all stages of delivering healthcare, but never more so than during the transition from the pre-IMC model that Jason described previously into the integrated managed care environment over the last 5 years. These partnerships functioned to achieve a number of goals, including bringing providers into a new system that many of them had never experienced before. Elements that might at this time seem relatively basic, such as submitting encounters, negotiating contracts with multiple organizations simultaneously or one after another. There were many challenges for our provider partners, both from a clinical perspective as well as from a financial and contracting perspective. It was very important for us to keep several goals in mind, including implementing all contract requirements while also trying to reduce administrative burden, or at least prevent from adding additional burden to our providers. Examples of how we achieved this was working with the state and the other managed care plans, traditionally viewed as competitors, but in many ways collaborators and partners in this case, to streamline billing and encounter guides, to simplify documents or replace multiple versions of a document from the different managed care plans with a single version that all could agree to in the interest of simplicity and reduced burden for providers. Also developing a prior authorization grid to assist providers with understanding the process or processes required for each of the plans, and whenever possible, aligning those processes if that could be achieved. There are other important priorities as well, such as minimizing confusion, and again, a principle of simplicity and consistency balanced with an eventual desire to innovate and improve. There were other collaborations in addition to those with providers and with our state partners that have been very important and remain so, including working with national thought leaders like the BRIE Collaborative and their principles of integration and moving along an integrated care continuum. The AIMS Center at the University of Washington with their very well researched and implemented models around collaborative care for a range of behavioral health conditions that can be achieved in primary care environments. The Behavioral Health Institute, and also the Alcohol and Drug Abuse Institute associated with the University of Washington. All of these with the intention of translating best practices from the research and implementation areas into our own Washington system of care. Additionally, internal efforts within Molina that took a great deal of work in order to align our own staff's ways of thinking around moving from more traditional siloed teams like physical health care management and behavioral health care management, really trying to cross-train all of our staff at all levels of the organization, clinically and non-clinical teams, to thinking more holistically and breaking down barriers at every opportunity between previously separated teams and ways of thinking. Next slide, please. Successes in early integrated managed care over the first few years. Our team has come to see several distinct phases in the implementation of integrated managed care, from starting with the first year or two, as I talked about, helping providers to adapt to new processes and new requirements, figuring out where to send things and who to ask questions of, and then into something of a phase 2 around stabilizing the existing network. This was done, fortunately, Molina was able to retain nearly the entirety of the behavioral health network in Washington State in the regions that existed before integrated managed care, although that can at times create challenges with wanting to offer new and innovative services to our members. We are now in something of a third phase as we go from 2022 into the future years around looking to modernize and innovate with many existing partners from across the state, as well as new entities who have entered the market either in brick and mortar buildings or by doing telehealth in new ways to apply best practices of substance use treatment, mental health treatment, serving individuals with intellectual and developmental disabilities in new and different ways, trying to balance those new programs with the existing models of care. And then finally, as we look to the future in partnership with organizations like Drew's Excelsior team and Jason and his colleagues at the Healthcare Authority, we have a number of new programs that we may have more time to get into during the Q&A later, both state-led as well as MCO and provider-led, new programs to fill gaps, adding additional levels of care across the system of care in Washington, and also coming up with new ways to blend funding from multiple sources to fill the needs of our Washington Medicaid members. So with that, I will turn things back over to Tom to lead us into our panel discussion.
Thanks, Sasha. I'm going to invite all our panelists to come on camera. We'll dive into, I think, many of the important issues that you all touched on as part of your brief overviews. I want to start with the member or the beneficiary in terms of engagement. You each touched on the member. I just think back to the transitions that we went to in Arizona as well. But think about member engagement and beneficiary engagement and what that looked like. Drew, you touched on the fact that this was over a number of years, as did Jason in his overview, and Sasha, you touched on some of the collaborations. But let's talk about member engagement. Drew, I want to start with you. As you thought about this change, as you thought about the progression towards integration, what does member engagement look like from the provider perspective, not only in terms of the education around these changes that were being driven, but also just around thoughts of whole person care and integration for an organization like Excelsior?
Yeah, great. Thank you, Tom. Thanks for starting with me as well. One of the things that was most important to Excelsior was how are we going to have sort of one voice for this system up front? And one of the things that we noticed early on was that we had this really driven, dedicated healthcare workforce in peer support. And so what we did is we really focused several years back on how are we going to put peer support at the very edge of our system, where that engagement with the community and population leads to very quick understanding, very quick engagement. And then how do we keep that person connected to our service participant while they move through our system of care, while they move in and out of our own delivery system, and how do we continue to help mitigate how complex the system can be? Another piece was the integration of behavioral health really does put a bit of strain on the already connected behavioral health provider delivery system. So one thing behavioral health providers are very good at is connecting people in terms of continuity to the next place or the next level of care. Integrating them into the system can, if done incorrectly, can create some challenges in how you keep some of those behavioral health referral networks moving smoothly and integrating them into basically other participants in the healthcare system in primary care and other settings that need to then actively participate in really sustaining that same delivery network.
Great, thanks. Sasha, to you, how did you all think at the plan level in terms of member engagement around the changes that were coming in the system and today, right? I mean, you sort of laid out the three different phases as you see it from the plan level. What did member engagement look like leading up to implementation and then going forward?
Sure. And I will qualify my remarks that I was not with Molina at the time of the initial rollout, but understanding, learning from my colleagues who were here at the time. So much of it came from a range of, there was a lot of emphasis on good communication with providers at provider symposiums that were co-led by the various MCOs as well as the healthcare authority as well, to get the message out about what was changing, when it was changing, why, and how that would all work. And there was also direct member communication in both written form and then also for individual members. As I said, I talked about some of the internal changes we made to cross-train and bring our own staff up to speed on integration, that they were working in a different environment starting in 2016, 2017. And that's honestly been a work in progress as we have membership changes over the years and folks may move from one MCO to another or on and then off Medicaid and back on again, making sure that all of our staff from on the member services line, our care management staff, anyone who works either on the phone or out in the community with our members is well versed in the current system and the changes that have happened, so they can explain and help navigate confusing processes and make sure that our members know who to call. One major advantage of the transition to integrated managed care is that with few exceptions, members can really call Molina for all of their needs. There are a couple areas where there's still kind of split coverage, which creates some unique challenges, but really encouraging our members to call us as their primary and often sole health plan has been a real advantage.
Great, thanks. Jason, the state level, the complexity of this and member engagement, and how did you all think about it throughout the process and to today?
Yeah, and thanks, Tom. I think that Sasha and Drew, you covered it well. And there was a question in the Q&A, which I answered. I typed out an answer that touches on this question as well with regard to how we can build that trust and relationship with providers, particularly to trust a system and to actually have to dedicate through significant change. And there is no doubt trouble and complexity and huge challenges with regard to that. But as I think, Sasha, you mentioned, the communication and not, it cannot be just communication. It has to actually be building that trusting relationship. And that takes time and dedication. And we're not there yet either, even after so many years of work on this. I think Drew and I, for example, have a good trusting relationship, but it's still new and we still have to perform. And if I fail to do something that I promised to do, or certainly Sasha from a managed care plan, trust is hard to build and easy to break, right? And so we have to just continue at it. And then I think really critically, we have to perform. So the metrics matter, the network adequacy matters, working with providers and figuring out new innovative contract methods. For example, we have a real challenge for 2023 rates because utilization is down a bit on the behavioral health side. And we don't exactly know why. We know we have 400,000 people on Medicaid due to the PHE pandemic requirements because they're not necessarily recertifying. They may not be using services and or it could be workforce challenges. So how do we have communication with providers and in an environment where we do not know all of what is happening? And so we're living that right now, and we just have to continue talking, continue meeting. We take advantage of every single opportunity to meet our behavioral health providers, and every single access point is available, including you can email me directly and I will follow up. And everybody knows that. I might not be able to answer everything or get the answer you want, but we will follow up. And so just some basics along those lines.
Sure. Great. Thank you all for that answer to that question. The next one I'd like to dive into is data. So when you look at the system, the complexity of the system, again, it was when we went through this in Arizona, you start from the perspective that behavioral health providers were like the forgot providers during the electronic health record incentives, right? So they start with a disadvantage just in terms of that, not having the infrastructure of some of their counterparts in the physical health world. But we're going to start with you, Jason, and we're going to work back through Sasha and then Drew to think about data and how did you all think about, in order to achieve what Drew laid out in terms of the vision around care coordination and being able to support a holistic plan for the member, part of that requires data infrastructure that I think in many states is challenging to be able to help build out for the behavioral health providers, just given, I think, the limitations of some of the federal incentives that have been out there and some of the data sharing elements of the behavioral health system, that face further scrutiny beyond just typical standards. So Jason, data, how'd you think about it through integration?
I think that's an incredibly important and still developing topic. I'm thinking about criminal legal system and reentry work. So not only with our behavioral health providers, but to share that information to with our legal system and our behavioral health providers and primary care providers. Let's get as much primary care lower level behavioral health services served as well. And we are still tip of the iceberg. Rural providers particularly are challenged with even having EHR. So we are investing in EHR as a service where the state may contract and then offer. We are still offering Zoom licenses to providers, many of which are behavioral health providers. So something that the state finances, Zoom licenses. We're not doing that as much anymore, but through the pandemic, we really just opened floodgates. Hey, let's get as many people as possible. And it worked because our telehealth numbers were way up. But that data sharing, EHR, community information exchange, Tom, in terms of talking about community-based organizations, non-healthcare related providers, so critical to communicate across those systems as well. It's a tip of the iceberg in terms of just developing systems along those lines that work as well. So a lot of work ahead of us here.
Sasha, you want to take on data from the managed care perspective and how you all have been dealing with partnering in the behavioral health community and thinking about integration to get to an integrated platform of sharing information?
Sure. I think this is a great topic and it could go in a number of different directions. My thoughts, staying on topic as much as possible. I think data is super powerful when from a guiding perspective. Data can be super powerful when we get the right type of data in front of the right people. They have time to review it and act on it. And then there are solutions readily available to achieve whatever goals we have with that data. And I give that overview, my way of thinking about it, because at times we, in the last couple of years, I find myself and our plan swimming in data, right? Lots and lots of reports that are automatically generated from our own Washington plan, from our national company and dashboards, and then also reports that go bidirectionally from the state to Molina, from Molina to the state. And it can be a challenge carving out time to review all of these various data sources for any individual or for entire teams, and then also trying to figure out how to prioritize responses based on the subject at hand. A couple of examples when we're thinking about campaigns that we can do inside Molina to improve on some of the agreed upon measures of quality care around readmission rates, around access to care or timely follow-up after visits to emergency rooms and hospitals. Also standards around or national measures around medication adherence for common psychiatric conditions. We receive reports like that all the way down to the member detail, and can also not assign every single individual member with a person to do outreach with them. So we're thinking more and more about triaging and population-based interventions that can achieve some movement on those overall larger population goals to show improvement in the data, while also making sure that we have higher intensity outreach either from our own employees or from partner provider organizations to reach out and support the members who are in highest need.
Drew, let's hear from you in terms of data and how your organization has thought about it, really to be able to get, the best needs met in terms of care coordination.
Yeah, so many things come to mind. One is that as we think about access to participant information, we have to think about it in terms of health and wellness, not simply their medical record. We have to think about the record being something much broader. That being said, that's not an easy discussion to navigate when there's a lot of regulatory minds at the table. And so we've got to think about it really comprehensively, and we have to spend a lot of time unpacking that. Another thing I think about is the information that's needed by our state partners, needed by our government partners. We have to find ways to get that data and get it there quickly and efficiently without requiring a lot of providers with limited capacity to build those systems internally. We've done a bit of that ourselves, and luckily we had that expertise. But that is something that comes to mind as a potential barrier. The other piece is accountability, particularly of the behavioral health providers. The data is necessary, it's needed, but a lot of these providers didn't have the necessary infrastructure to deliver that information. And so, for example, you've got, when behavioral health is carved out, you perhaps have a government system of RFPs, and you've got providers and communities raising their hands saying, we will care for the community in this way. And so then what do? We fund those providers' administrative capacities. We fund their service delivery capacities. We don't fund their technological infrastructure. And so when we had this integration task ahead of us, we heard a lot about moving from, volume to value. And I'll just say, a lot of the behavioral health providers were sitting around saying, we need to move from value to participating in volume. How are we going to participate in the claim management systems that track the data? Because until then, perhaps we didn't. So data has to be a broader conversation. It has to, it has to bust the corners out of our claim management system boundaries around how we get data. And at the same time, the behavioral health providers have to be held accountable to provide the encounter data and provide the evidence of what they're doing. Otherwise, we can't really move the entire system forward.
Great, thank you so much. Yeah, a lot to chew on the data front. And again, it's nothing that can be accomplished overnight, but it's got to be something that's focused on incrementally to really move the needle over time. If you really want the system to improve and meet, the overarching goal of really being able to provide holistic care, data is an important piece of that. Just a reminder for folks, if you want to go ahead and put a question in the Q&A chat, we're happy to look at that. And we've got one now for you all. And this really goes to the issue of change is difficult. There's a lot of concerns around moving towards an integrated platform. You hear it from advocacy organizations, from providers and others. CMS published some information recently that I thought was interesting. In 2013, 56% of the population in Medicaid received services through an integrated MCO platform. By 2018, that number had grown to 70%. So you're seeing a trend where more and more of the Medicaid population is in an integrated MCO platform. But obviously, there's still a number of states where there is the carve-out model. There's still in those states concerns, and even for states that have transitioned, I think there's concerns in terms of how to continue to grow success with that model. So Drew, I want to start with you. As you think about the journey Washington's been on, how did the state and how did providers sort of overcome those fears of change? And if you could identify one or two key areas that were really important to focus on in terms of really being able to be successful as a result of that change, what would it be?
Well, two things. Let's see here. I think first would be the collaborations between providers. Providers have to come together. They have to talk about fears. They have to talk about the perceived risks. They need to get the the competitive nature that may exist within a community around what dollars are available, and really link arms and think broader and bigger about how are we going to raise the delivery of care for our communities together. And so the first piece is just finding those collaborative partnerships, finding those system partners that need one another, and facilitating some time to work through the I've got your back, you've got my back discussion. Another piece is that, and I'll skip back, this is sort of that was 1A, this is 1B. Again, behavioral health providers have done a good job building the referral networks. A lot of that was done between them, not relying on a third party. And so in an integrated model, you have to work with the state, you have to work with the payer to help preserve what those referral networks and pathways are. Jason's slide showed a little bit of a challenge in terms of youth SUD outpatient. That referral network maybe was looking better before integration than it does now. I don't know, but I would presume that that could be an example of what a state could do to ensure that those things are really looked at and thought through. Another piece is that you can't give up. You start these efforts, you don't spend a couple of years and turn around and say it didn't work. And when you look back and you talk to people in our system and providers in our communities that have been here decades, we've done a bit of this in the past and we've sort of turned around too quickly. We have to stay the course. We have to make sure that people get access to a comprehensive system and that they don't have to find transportation, they don't have to find information, they don't have to navigate something so complex just to get the care that they need. We've got to keep it on course.
Yeah, thanks so much, Drew. And then Jason, from your perspective, I mean, this state obviously was one of those organizations driving this change. And so how did you think about it in terms of really dealing with, providing the education, talking to policymakers, talking to providers, talking to MCOs? How did you deal with this, the constant challenge that we face in terms of driving change into an organization that sometimes prefers the status quo?
Yeah, I think, Tom, there's different phases to this too. So there's sort of the initial phases of just policy and investigation and working with the legislature and different advocacy. That was an incredibly challenging phase in of itself, stemming from transformation work with regard to our initial Medicaid transformation waiver in Washington over the post in a Medicaid expansion era, so 2014 to 2016, and really starting slow. So one region of the state at a time, and there was just really one region for the first 2 years. Second region was added year 3, and then slowly the rest of them came after. So there was a slow move in that regard. So it was a long time working with the legislature. It was connected to transformation, and then a slow move. All understanding that, again, end of the beginning. So there's a lot more to do. And it was really just financing wise, with an effort on the clinical side and transformation to invest in clinical transformation as well. So the bidirectional clinical care and investing in that, with a particular emphasis, of course, on SUD and a hub and spoke model for SUD care. So now we have a lot of office-based, primary care-based SUD care in Washington, which was a huge transformation during this time. I would say that now, though, the phase is some immediate sort of crisis pandemic level work to invest in workforce. So immediate rate increases using some of the federal financing to help with that. The legislature's invested $100 million plus a 9% rate increase over the last 2 years. And then, that will come fully in effect in January. But also our commitment to future looking work. So we have a rate comparison study underway. So a behavioral health specific rate comparison work to understand what should be paid for behavioral health services. What are the actual costs? And then maybe create a more up-to-date fee schedule, maybe create a decision package to help fund those gaps in that fee schedule, in addition to investments in studying for, as I mentioned earlier, the certified community behavioral health clinic model as a means of transformation, and really a sustainable pathway, especially if we pay based on a prospective payment rate like we do our community health clinics today. And that might, I would submit, it should provide better financing for sustainability, for that workforce retention recruitment, but also comes with great promising from other states and even our local few clinics who are doing it today, outcome measures for access and quality. So we've got to invest in these future-looking things as well. So that commitment remains. Solve those initial problems, solve those immediate problems, or to the best of our ability, continue communicating, and then we must invest in those future-looking strategic efforts as well. Cannot lose sight of that.
Thanks, Jason. Sasha, I think you touched on several of these comments as part of your presentation, but I don't know if you want to elaborate more on sort of how the MCO saw itself dealing with the resistance to change.
Yeah, I'd love to. Let's see. I'll echo a couple of comments or themes touched on by Jason and Drew in the last few minutes. It's been essential to spend time face-to-face, ideally in person, and then over the COVID period where necessary by video, but with other entities, with folks from other organizations, in order to, as Jason talked about, build trust, establish relationships, and then maintain those while we've gone through a series of challenges. And even though our respective organization types, from state leaders to providers to the managed care plans, have the same general goals in mind as far as achieving a cost-effective, clinically effective system of care that serves all the folks in Washington who rely on it. Sometimes our perspectives are different, and they can vary based on the different ideas about what measures should be used and what we should be measuring now compared to 5 years ago or 10 years ago, and where the priorities should lie. Also, how we reward folks for achieving the highest objectives on these goals as we look to more value-based contracting. And so I would say having those difficult conversations over the last, especially the last 6 to 8 months, I know for myself and my own team at Molina, where I've spent a lot of time, again, on the road, visiting with groups like Drew's team at Excelsior, other folks across Eastern Washington, Central Washington, Southwest, across the state, including the places that are harder to get to, and therefore they don't get the face-to-face visits with the regulators and with the payers, the health plans, as often. So rebuilding relationships where there have been challenges has been important, and then also problem solving together. Honestly, I believe in my heart and my bones that the integrated system from a financial perspective makes sense and is a superior arrangement. As a psychiatrist who went through medical school and came into practice, I'm somewhat still in the minority as far as I've never practiced in a traditional standalone clinic by myself. I've only worked embedded within primary care across teams of other folks and really taken that multidisciplinary model. And it just makes intuitive sense to me that the payment would be integrated. And I've learned that's been confirmed over the last 5 years in MCO work, despite the challenges that come up. And we might think, okay, maybe if we pay for it separately, then somebody will specialize in it and do a better job. We've tried that experiment across the country and in other states. And Tom, you could probably speak more to the historical perspective on that than I can, but I think we, as Jason and Drew have both said, we have a lot of room still to go, a lot of work to do together. But I get really excited, start of every Monday morning like today, thinking about how much can we pack in the next 5 days to develop these new initiatives, to bring funding sources together, to, if there's a rule in place, Jason and folks at the HCA have been able to advocate for changes, like maybe the rules should be different. Maybe we talk to the legislature and they can pass a bill that gets funding that can apply to a new way of delivering service to close these gaps. And it's not A, B, or C. Somebody thinks of B and a half or a quarter of B and 3/4 of D. Where did D come from? Well, it just got passed. So we are constantly tinkering. And that's really like, as we move from the end of the beginning, as Jason said, to the next chapter, that's what gets me passionate about. I often tell folks, I didn't go to medical school and become a psychiatrist dreaming of working for an insurance company. But I ended up in this position, and I'm excited to do it every day because this is where the change is happening, for better or for worse, right?
Right.
And being a part of this process and trying to figure out how we can shift it in the right direction, one incremental step at a time, is really exciting to me.
Yeah, these are large systems. They're difficult to change, but you all have tremendous momentum around this. It's great. We're going to build on Sasha's energy here in the last 2 minutes. You each have about 30 seconds on this last question. So what tells you you're headed in the right direction? One tidbit, one piece of data, one story in 30 seconds or less. Sasha, we'll start with you. You just gave that passionate summary there of where you're at, but 30 seconds or less, what tells you you're headed in the right direction with integrated care?
So we have this new project that we are working on with Drew's group at Excelsior, right? To try to figure out how we can serve more, and with Jason at the HCA and his colleagues at the HCA, who spend a lot of time trying to figure out how to support youth in need, right? So there's a program across the state called Wraparound Intensive Services, right? Trying to figure out kids at high need, at high risk, have ended up in hospitals, behavioral health, all kinds of other needs that they have, physical health that's getting unmet because of their behavioral health challenges, and families in distress and in crisis. Kids are waiting too long to get into those kinds of programs. And then sometimes they stay in those programs for months and months or years without seeing meaningful improvement because of provider workforce challenges, transportation issues, et cetera. So in the 5 seconds I have remaining, we're working on a new initiative to deliver a virtual intensive short-term model of wraparound intensive services to serve youth without geographic constraints, because it's virtual, from across the state, including rural areas and areas with longer than typical times to get into these services, and measure a distinct set of outcomes, not only those that are already part of the WISE program, but new and we feel necessary outcomes to try to track what's happening along the way, get kids moving through that process and doing better, because kids get better when given services. That one thing really cool about young people is they change quickly, for better or worse. So in Drew's group, and support from Molina and the Healthcare Authority is serving those kids, and we can get them in front of a camera with their family in the room, we're pretty confident that good things will happen, and something that would not have been possible before IMC.
All right. So Drew, you got like 10 seconds left. Anything you want to add?
What I'm going to share with you is the difference from my experience talking to the folks at engagement and assessment. Before integration, we had very, very just tough experiences. People felt heard, but we didn't know exactly what to do next. Today, I'm hearing from those engagement and those assessment clinicians that people are walking in and sort of saying, wait, I can get that right now. I can get both of these, and really often coming to tears. And so those engagement and assessment clinicians are feeling empowered after integration. They're feeling like they're finally able to deliver more for people. And I think that's really the whole point here.
That's an amazing testimonial, Drew. Thanks. Jason, close it out.
I think Sasha and Drew said it best, Tom. And
all right,
nothing more to add. I think we covered it. Great.
All right. Thank you so much, all of you, for joining us. Thanks for everybody that was out there attending the webinar today, and have a great day. Thanks so much.
All right. Take care, everyone.
Thank you.